My name is Gene DeCastro, and I'm a palliative care physician at the James J. Peters VA in the Bronx. Thank you for joining the talk today, which is titled Palliative Care in Hematologic Malignancies. As part of this session, we will place an emphasis on bone marrow transplantation and cellular therapies. I have no financial disclosures or conflicts of interest to report. There are 5 main objectives. First, we will identify fundamental concepts when caring for patients with hematologic malignancies. Next, we will review key patient and provider considerations with respect to care delivery in this cohort. Third, we will explore important clinical aspects of the bone marrow transplantation process that are relevant to providing palliative care consultation in this population. Fourth, we will discuss chimeric antigen receptor T-cell therapy, also known as CAR-T. Lastly, we will go through mock board review questions. The last 8 years have shown an explosion of inquiry at the intersection of palliative care and hematologic malignancies. There were studies highlighting topics like patient-reported outcomes for patients with blood cancers, gaps in access to palliative care, assessment of hospice utilization, patient and hematologist perceptions of palliative care and hospice, prognostic discordance between patients and hematologists, clinical trials involving palliative care in bone marrow transplant recipients or those diagnosed with leukemia, qualitative work evaluating barriers to hospice and consultation. It's been an exciting time for those operating in this space. Hematology patients are historically underrepresented in the sphere of palliative care. This body of work has illuminated several important distinctions that allow palliative care providers to more effectively interface with patients who have hematologic malignancies. First and foremost, there's a tremendous diversity of pathology and even more complexity within a given diagnosis. Leukemias, for example, there are 4 main types. There are acute leukemias and chronic leukemias. Even within the acute leukemias, there may be high cure rates in conditions like acute promyelocytic leukemia, aka APL, versus acute lymphocytic leukemia, ALL, which has high chemotherapy response rates, but also high relapse rates. Lymphomas are a broad disease category. These are reportedly over 70 different lymphoma subtypes, and 90% of these are non-Hodgkin's in nature of B-cell or T-cell origin. Additionally, there are myeloproliferative diseases, there are myelomas, and these myelomas may have a protracted disease course, where after initial treatment, individuals spend years on maintenance therapy. Also, across disease types, there may be many different types of responsiveness to treatment or relapse rates based upon molecular and cytogenetic profiles. Furthermore, many of these illnesses are commonly found in the geriatric population. For example, the median age of onset for acute myeloid leukemia is 68. Given the lack of representation of older patients in clinical trials, it can be a challenge extrapolating treatment responses and symptoms to that cohort. Prognostic uncertainty in hematologic malignancy contributes to significantly low rates of palliative care and hospice utilization for transplant and non-transplant blood cancers, especially since these diseases may have a higher response to chemotherapy compared to solid tumors. Importantly, transfusions are a pivotal part of the decision-making calculus for patients along their illness continuum and can be a challenge when conversations about hospice arise. The critical thing to recognize is that patients with hematologic malignancies are more likely to die in the hospital with respect to their solid tumor counterparts. Moreover, there's a high degree of resource utilization within the last 2 to 4 weeks of life when assessing chemotherapy use, emergency room visits, and admissions to the general medicine floors or intensive care units. As an extension of these trends, the venues for death of these hospitalized patients follow suit. A high percentage of these patients die in the intensive care unit, and conversely, a low percentage die in palliative care units. The pairing of Medicare and SEER data have demonstrated that palliative care consultation is rare and late in patients with hematologic malignancies, which may impact these trends. The overarching question is, how should palliative care providers interface with these populations given the diversity of illness? One perspective underscores the idea of aligning palliative care with trajectories and outcomes for different illnesses. For example, imagine this large pool of patients with blood cancers and separating them into different groups. low symptom burden, and low mortality. This group may be indolent lymphomas like follicular lymphoma. These patients may benefit from palliative care when the disease progresses or if the prognosis becomes poor. When there is a moderate symptom burden and moderate mortality, like aggressive lymphomas, for example, diffuse large B-cell lymphoma, one may consider early intermittent palliative care. When we look at high symptom burden and high mortality, like what is seen with acute leukemias like AML, one can consider longitudinal palliative care implemented early. Finally, diseases with prolonged periods with low symptom burden, like myeloproliferative neoplasms, such as chronic myeloid leukemia or CML, teams may need to identify triggers for palliative care. Dr. Arij El-Jawari has been at the forefront of generating a large research and knowledge base to help accelerate the pairing of cancer care and palliative medicine for hematology patients. When contending with hematologic malignancies, there are three domains that patients, families, and providers may have to navigate together at the outset of the diagnosis: prognostic uncertainty, the complexity of treatment options, examining the potential role of trials of critical care during their treatment. One illness that highlights all three aspects of such complexity is partially illustrated here in this slide. This is a conceptual model for treatment selection for those with newly diagnosed AML. Factors like chronic age versus physiologic age, frailty versus robust performance status, multimorbidity, previous antineoplastic agent exposure, and molecular and cytogenetic profiles of the cancer itself can help to refine agent selection, and this ultimately resulting in a bifurcating algorithm centered around intensive versus non-intensive treatment, coupled with the potential for oral oncolytic therapy. The landscape of treatment options is ever expanding, so it's important to utilize the experience of your hematology partners and teams. An outstanding primer put forth by Drs. Jason Webb and Dr. Thomas LeBlanc is an absolute necessity for those at any point in their career or training. This top 10 paper addresses some nuances of care delivery across this pool of patients by discussing important ideas like the role of molecular cytogenetics in illness treatment, response, agent selection, and relapse risk. The nature of favorable response to aggressive treatment shaping the landscape of palliative care consultation. The high percentage of psychosocial distress for patients and caregivers being a source of unmet need. The historical context surrounding aggressive treatment and low palliative care consultation rates. There is an equally well-crafted companion piece more specifically focused on individuals with AML that is part of the top 10 series as well. I want to slow down here temporarily since this is one of the most important slides. For many patients with blood cancers, transfusions, be it red blood cells or platelets, may be a critical part of their care plan, surveilled, treated, and heavily emphasized. It can be a patient with impaired hematopoiesis from a disease process like myelodysplastic syndrome, or it can be a patient who has protracted myelosuppression after receiving chemotherapy. As a part of this strategy, patients have been counseled and taught to be highly vigilant about transfusions to avoid catastrophic GI bleeds or cerebrovascular events. A hematologist may sometimes refer to the use of transfusions without neoplastic treatment as best supportive care. When considering hospice for these patients, historically, transfusion support is not covered by agencies. This may feel incomprehensible to these patients and families. Some agencies may be able to provide red blood cell transfusions for symptomatic anemia, but continuation of the platelets is rare at best. This perceived gap in care has been noted by some informally and in studies as a potential reason for hematologists to be disinclined to refer patients to hospice. When talking about hospice and discussing transfusions, you may get thought-provoking questions such as, so do I just bleed to death? Will I choke to death on blood? Why isn't transfusion important anymore? How can I give it up? I feel so much better with transfusions. How will I know if I'm bleeding in my brain? Wait, hospice stops supportive care? Growing over the last several years is a body of evidence via clinical trials that adds credence to the notion that integrated palliative care is an impactful modality for those with hematologic malignancies. 3 key studies by doctors El-Jawari, LeBlanc, and Temmel focus on integrative palliative care for those with blood cancers. The first study was published in 2016, highlighting integrative palliative care for patients undergoing stem cell transplant. It was a single-site, randomized controlled trial where palliative care providers would see patients at least twice weekly during their stem cell transplant. And what was seen at 2 weeks were decreased rates of depression and anxiety, decreased rates of depression, and decreased rates of worsening symptoms. At 3 months, lower rates of depression and increases in quality of life were seen. At 6 months, lower rates of depression were found, as well as lower rates of PTSD symptoms. Subsequently, in 2020, a multi-site randomized controlled trial was conducted looking at the integrated palliative care for individuals with high-risk AML. These individuals were seen at least twice weekly during and after their induction chemotherapy and during all subsequent hospitalizations. What was also seen at 2 weeks were decreases in anxiety, decreases in depression, decreases in PTSD symptoms, and increased quality of life. At 6 months, there was a sustained impact across all of these domains. Lastly, in 2023, a multi-site randomized controlled trial was conducted looking at integrated palliative care for patients undergoing stem cell transplant. At 2 weeks, it was demonstrated that patients had lower rates of depression, PTSD, increased quality of life, and decreased symptoms. Let's pivot to bone marrow transplant. We will use the phrase bone marrow transplant and stem cell transplant interchangeably. I came across this slide circa 2016 in a presentation by Dr. Wu from the Mayo Clinic. The intention was to frame the role of bone marrow transplant and its impact in the quality of life for those patients. A parallel was drawn between quality of life trajectory of patients who have heart failure with the introduction of a left ventricular assist device and an individual who has a blood cancer who may receive a stem cell transplant. With the x-axis representing time and the y-axis representing quality of life, we see this undulating wave of downward in black representing the trajectory of quality of life over time and the possibilities of either improvement or worsening after having an intervention. The blue dotted line, A, representing accelerated reduction in quality of life. The green dotted line, B, reveals continuation along the trajectory. The magenta dotted line, C, shows improvement in quality of life for a sustained period of time until a decline later on. This is an analogous depiction between LVAD introduction and bone marrow transplant. And for me, this was my aha moment in palliative care. There are some important things to consider about the involvement about palliative care and bone marrow transplant patients. At times, the agreement between the hematologist and the patient can be described as a covenant, where the person recognizes there may be a need to be brought close to death in order to have a chance of survival. Additionally, as part of the selection process, patients have a good performance status and minimal to no symptoms, removing those factors as an entry point for palliative care providers. Moreover, bone marrow transplant team is likely to be highly adept at symptom management and particularly attuned to the psychosocial needs specifically tailored to transplant patients. The transplant team will also have a high degree of ownership of their patients. And as a consultant, it is imperative to emphasize with all of the team members that the treatment is in parallel and not in opposition. We will spend some time on this slide. Over 22,000 transplants occur annually. The overall goal is improving overall survival or progression-free survival. There are 2 types of transplants. The first is autologous transplants. As for the source of the cells, it comes from the patient themselves. They are harvested and stored prior to the procedure and infused after chemotherapy. The principal effect comes from the high doses of chemotherapy and repopulation with the infused cells from the patient. It is usually well tolerated with a mortality of less than 1%. Allogeneic stem cell transplants, the donor can be a sibling, a related individual, or unrelated individual that is matched through human leukocyte antigens. The effect comes from the chemotherapy and from that of the donor cell as well. The complication rates are higher, and the donor cells put the patient at risk for the development of graft versus host disease after infusion, as the T cells may impact or damage different organ systems. Transplant success is often dictated by disease type, disease stage, and cytogenetics. One study looked at 3-year survival post-allogeneic stem cell transplant and saw for patients with aplastic anemia, the 3-year survival was 78%. For those with early AML, it was 59%, and for those with advanced AML, it was 27%. This is a content-rich slide. The top half is an illustration that focuses on the source of the cells, autologous or allogeneic. Below that is a timeline and conceptual framework to understand what the bone marrow transplant period may look like. The patient will be admitted for conditioning. This is known as the pre-infusion period. This is where chemotherapy is administered. Also, there is a countdown, almost like a launch, day minus 10, day minus 9. During that period, total body irradiation also may be used. The inpatient pre-infusion period will vary in length and will be dictated by the conditioning regimen used for preparation. Symptoms may develop closer toward the tail end of this window. Next, there is days of the infusion, which is called day 0. Subsequently, there is the post-infusion period, day +1 and onward. The importance of this is engraftment. This is the period where the body begins to make new cells, usually between days 7 and 17, and the restoration of the absolute neutrophil count. During this period, before engraftment is complete, the period of count depletion is the time where team is monitoring for complications like infection, symptoms like nausea and fatigue. They're also monitoring for things like mucositis and end organ damage. And the typical complete hospitalization for bone marrow transplant without complications can usually be between 3 to 4 weeks. This slide was built by aligning 2 charts and anchoring them at day 0 of the infusion. Let's look at the top panel. Pre-infusion, prior to day 0, during the conditioning phase. This allows for the depletion of native cells, thus promoting a state of immune compromise. Post-infusion, after day 0, there's an expansion of infused cells and repopulation of neutrophils, CD4 and CD8 positive T cells and B cells. This period of neutropenia is where patients can be particularly susceptible to infection, colitis, and mucositis. There can also be renal thrombotic microangiopathy and hepatic vaso-occlusive disease, but those are beyond the scope of the talk today. Next, we'll focus on symptoms. Fatigue is a highly prevalent issue in patients with hematologic malignancies, as well as bone marrow transplants. It can occur during and persist after the transplant. The differential or causes can be quite broad and may not necessarily just be linked to chemotherapy or anemia. One has to consider things like pharmacotherapy, depression, adjustment disorder, isolation or loneliness, insomnia. There are multiple screening tools like the fatigue symptom inventory, the brief fatigue inventory, and others. It can be transient and a challenge to manage if it persists. Evidence suggests cognitive behavioral therapy can be impactful in the post-transplant period. A large body of work is being generated by Dr. Hermione Amanu out of Boston, who has explored the nature of psychosocial and psychiatric symptoms in those undergoing bone marrow transplant. First, we will discuss anxiety. One of the differences here is that the bone marrow transplant is a scheduled event. So sources of anxiety may differ than those typically associated with a new diagnosis. Additionally, its presence is variable and may occur for different reasons across the transplant process, before, during, and even after. Factors outside of the hospital may be of significant involvement or interest even though the patient is hospitalized. The patient may be thinking about how this hospitalization will change their relationship with their spouse. Will it be a hardship in terms of their caregiver, in terms of financial support? What will happen in terms of the illness? Will they develop symptoms? What will happen if the transplant doesn't work? What will happen if the transplant works but the disease relapses? What will happen in the post-transplant period in terms of infectious exposure at home or at the supermarket? What will happen in terms of the patient and their increasing solitude or their loss of personhood and role in society? There are a number of useful screens for anxiety. The Generalized Anxiety Questionnaire, the Beck Anxiety Inventory, a Hospital Anxiety and Depression Scale is used in some clinical trials. It's useful to employ the support and strength of the interdisciplinary team throughout this process, and at times brief trials of low-dose benzodiazepines may be considered, but be mindful of polypharmacy associated during the post-transplant process. Patients can have a rich emotional prism throughout this process that merits exploration. Discontent may be labeled as depression, but some of the issues may be adjustment disorder, anxiety, avoidance, cognitive haze, cognitive fog, cognitive slowing, may be labeled as chemo brain due to chemotherapy, steroids, or immunosuppressive therapy. Delirium can be an issue. During engraftment, prevalence of delirium can be up to 35%, or there can be feelings of feeling trapped and isolated or disempowered. These can also be common symptoms that can be misinterpreted as depression. Screening tools such as PHQ-2, PHQ-9, Geriatric Depression Scale, and HADS, Hospital Anxiety and Depression Scale, can be utilized. Now, the prevalence of post-traumatic stress disorder symptoms is roughly 20% in transplant patients. However, they may not meet the criteria for full PTSD. There can be events that preceded the admission that may be triggered by the hospital setting. Recollections of being intubated, memories of mucositis, intrusive thoughts or flashbacks of being in the intensive care unit or being very ill. A study in 2021 by Dr. French noted that individuals with clinically significant PTSD symptoms had high rates of intrusion, intrusive thoughts, avoidance, and hypervigilance. Insomnia can be a very common problem. Regarding prevalence, 50% of patients have insomnia prior to stem cell transplant, 82% have moderate to severe insomnia during the transplant itself, and 43% have insomnia during the post-transplant period. This can be mood-related due to uncontrolled symptoms like pain. It could be actually chemotherapy-related or impacted by corticosteroids causing alterations in the sleep-wake cycle. Nocturia can occur due to high volume of IV fluids during the receipt of chemotherapy. It can be the ambient environment, and potential challenges are not only the treatment of insomnia, but shared decision-making with a team because of the variability with which insomnia is treated, and developing a consensus strategy which may differ than yours can be something you'll experience as a consultant when caring for these patients. Pain can be a particularly striking and debilitating symptom. Commonly, things like colitis, enteritis, and mucositis are issues. In the post-transplant period, acute or chronic graft versus host disease can occur. During the transplant, people may experience diffuse bodily discomfort from being in bed so long or being immobile. Less commonly, chemo-induced peripheral neuropathy occurs in the post-transplant setting. This paper, How I Treat Pain in Hematologic Malignancies Safely with Opioid Therapy, is certainly recommended. And it's an excellent read because many of these patients may not die in the acute setting, and they may not be at the end of their lives. So certain risk mitigation strategies may need to be in the foreground when making decisions about opioid therapy. Mucositis. This can be an extremely uncomfortable symptom ranging from mild oral paresthesias to pain of the highest magnitude, where people describe the sensation like they feel as if they're swallowing chewed glass or razor blades. The pathogenesis of mucositis has been linked to direct toxicity of antineoplastic treatment, like chemotherapy or radiation, cytokine dysregulation, or disruptions of the microbiome. What's most important to recognize is that the disturbance can occur at any point along the GI tract. At the top right, we have panels to illustrate and accompany the grading scheme of oral mucositis. Panel A is grade 1, where the person may be asymptomatic or have mild symptoms and intervention is not indicated. Panel B is grade 2, where moderate pain or ulcers develop that do not interfere with oral intake, and they may be present in a situation where diet needs to be modified. Panel C, or grade 3, is where severe pain is interfering with oral intake, and panel D is grade 4, with reports of life-threatening consequences or urgent intervention needed. This may warrant a nasogastric tube placement and is especially problematic due to the need to meet caloric demands. Regarding the prevention of mucositis, expert opinion suggests best oral care. This involves the brushing of teeth several times per day. It can be up to 4 times per day, using saline or bicarbonate rinses between 5 and 6 times per day. Additionally, some recommendations for the use of ice chips, also labeled oral cryotherapy, may be helpful in prevention as well. Or in terms of pharmacotherapy, recombinant human keratin growth factor 1 is also utilized during autologous stem cell transplant. This is known as Kepivance, and we'll revisit this topic very shortly. When it comes to mucositis, we transition away from prevention and move toward treatment, and opioids are the preferred strategy. IV push opioids as needed or demand dose only PCA can be an excellent strategy to provide access for a condition that has an unpredictable course. There is some data to support morphine swish and spit solution. Sodium bicarbonate rinse can also be a benign strategy that may confer some benefit. Other agents that are gaining favor are doxepin rinses, oral ketamine rinses, and some evidence which is limited for gabapentin solution as a treatment, as a topical treatment, not for the prevention of mucositis. You would like to avoid NSAIDs given their ability to inactivate platelets in patients who are already thrombocytopenic. Additionally, you probably want to avoid standing Tylenol because these patients may be not able to mount an increased white count due to the conditioning regimen and blunted marrow activity. So fevers are necessary to help signal new infection. For patients who use Kepivance, they can have substantial dermatologic changes. Skin reddening or darkening can occur, and these cosmetic changes can be quite bothersome to patients. Skin friability can also be a challenge, especially for patients who are spending large periods of time in bed, and repositioning may lead to tears. Individuals using this also feel sensations of dental or gum pressure, and not necessarily pain, but a fullness or a discomfort, but not necessarily pain, just a strange feeling of pressure. Most importantly, patients can feel a pasty sensation or coating on the tongue, which makes them less likely to eat, creating further issues with feeding. Taste is particularly disruptive and can occur with allogeneic or autologous stem cell transplants. There are multiple contributing factors: chemotherapy, which may be agent-specific or dose-dependent, medications that may cause abnormal taste, or hyposalivation, which impacts taste. Infection or smell disturbances can also contribute. There may be ageusia, which is no taste, hypogeusia, which is diminished or blunted taste, or phantogeusia, which is sensing a taste which is not present. For example, they may feel a very salty taste, even though they're not having anything that salty. This can persist for months. There could be non-pharmacologic strategies such as food rotation when working in concert with a nutritionist, or pharmacologic therapies like a trial of zinc or dronabinol. Loss of appetite can be a significant problem. So just to contextualize the issue, someone can have a reduced appetite for 1 to 3 weeks. They'll have reduced food intake, distorted taste, fewer culinary options, and taken together can really impact the nutritional status. And why is this important? Well, a 2019 study looked at stem cell transplant recipients, and it evaluated functional impairment, fatigue, muscle wasting, and quality of life. And what they found was that the stem cell process itself contributes to reductions in the 6-minute walk test, lean mass, and the fat mass, with increasing nausea and fatigue. So that, coupled with reduced appetite, can pose a real problem for patients and contribute to increased frailty later on. As we move toward nausea and vomiting, we're going to place an emphasis on chemo-induced nausea and vomiting. This is a nice graphical representation of the timeline for chemo-induced nausea and vomiting, highlighting receptor profiles associated with it. The anticipatory phase, which is pre-treatment, the acute phase, which is time 0 to 24 hours and mainly serotonergic, and the delayed phase, which is 24 hours and beyond, which has a greater influence by substance P over time. What we know is that there are 4 main classifications of emetogenic risk: high, moderate, low, and minimal. Now, these conditioning regimens can fall into any one of these categories, and oftentimes people are on prophylaxis that is multi-agent in nature, outlined to the right. What's important to highlight here is that if nausea and vomiting is the predominant issue, the Rhodes Index can be a nice tool in characterizing the impact of nausea and vomiting on the person's quality of life during transplant. Reviewing the emetogenicity and the nausea and vomiting timeline can allow palliative care providers to work with transplant teams on determining what second, third, or fourth line options can be helpful to address refractory symptoms. There's a significant risk mitigation standpoint due to polypharmacy in transplant recipients. For those with breakthrough nausea despite prophylaxis, consider agents outside of the classes that are currently being used for prophylaxis and do so on an around-the-clock basis. Olanzapine can be a helpful strategy as well, with once daily dosing, but being aware that olanzapine can infrequently cause neutropenia. What I want to discuss with this slide is the fact that a number of medications have opportunities to generate a greater degree of interactions from a serotonin standpoint, a dysrhythmia standpoint, sedation or respiratory distress, and P450. To the left, we have a number of medications that you may see during the stem cell transplant process, and there may be compounded risk. So it's always important to try and identify and minimize risk when you can. When evaluating bowel movement dysregulation and the symptom burden associated with that, we're looking at constipation or loose stool. Constipation occurs less commonly. The culprits are usually immobility, opioids, poor PO intake of dehydration, or some combination thereof. These converge and create that issue. But more commonly, you'll see loose stool, and once infection is ruled out, loperamide can be useful in helping to ameliorate the symptom. What I want to do is spend time focusing on chimeric antigen receptor T-cell therapy, also known as CAR-T. It's a very exciting strategy in the collection of anti-cancer treatments. It's an autologous-based treatment where T-cells are harvested, reprogrammed, engineered to express receptors that allow for discrete targeting once infused back into the patient. Currently, it has FDA approval for B-cell ALL, mantle cell lymphoma, multiple myeloma, B-cell lymphoma subtypes, high-grade B-cell lymphoma, follicular lymphoma, and primary mediastinal large B-cell lymphoma. Oftentimes, it is not used as a first-line treatment, so this represents the last chance for people who have refractory or relapsed disease. What also makes this attractive are the response rates and rates of durable remission associated with this treatment strategy, extending the overall survival rate for individuals for quite some time. The challenge is it's hard to identify who will or will not have a good response. And being a relatively novel therapy, there can be some worry or anxiety surrounding the process for patients who may try to explore these things on their own online. And what's also important, similar to bone marrow transplants, are the trials of critical care. These are another important consideration when it comes to CAR-T therapy, which we will delve into later. Like bone marrow transplants, there is a pre-infusion phase with conditioning, day of infusion, and post-infusion period. Health Services research study in 2023 by Kish and colleagues evaluated hospitalization stays for CAR-T in the United States for patients and put the median length of stay at roughly 12 days. With respect to long-term outcomes following CAR-T therapy, what we know so far is that some patients are having survival for years beyond treatment, several years beyond what conventional chemotherapy would have afforded them with traditional agents. The highly targeted strategy of receptor-mediated action helps to minimize the likelihood of off-target adverse effects, aka acting on unintended targets. When compared to individuals who have bone marrow transplants, individuals undergoing CAR-T therapy have fewer and milder symptoms. Fatigue is still prevalent, but may be a consequence of the conditioning regimen and or other factors throughout the process akin to bone marrow transplant. At this time, there are several generations of CAR-T constructs, and the intracellular domains that vary across these different generations may shape the extent or degree of adverse effects for these patients. What does this trajectory look like in terms of symptoms for individuals undergoing CAR-T therapy? A study by Dr. Johnson in 2023 assessed patient-reported outcomes up to 6 months post-CAR-T infusion. Quality of life and depression worsened by 1 week and improved by 6 months after CAR-T. At 1 week, 52% of patients reported severe physical symptoms, declining to 28% at 6 months after CAR-T. Longitudinal patient-reported outcomes across psychosocial domains were evaluated next. At the outset of this study, baseline levels of anxiety, depression, and post-traumatic stress disorder symptoms were evaluated also. They were at 30, 26, and 29% respectively. 6 months post-CAR-T therapy, those percentages had decreased to 22, 18, and 22% respectively. As we shift away from patient-reported outcomes, we're going to now address some modality-specific related issues that can occur with CAR-T. There are 2 major adverse outcomes that can arise. They are cytokine release syndrome and immune effector cell-associated neurotoxicity, also called ICANS. First, we will talk about cytokine release syndrome. And there's an operational definition, which is a supraphysiologic response following any immune therapy that results in the activation or engagement of endogenous or infused T cells and or other immune effector cells. Symptoms can be progressive, and it must include fever at the onset and may include hypotension, capillary leak, hypoxia, and or organ dysfunction. This occurs as a consequence of cytokine efflux and the expansion of CAR-T cells with further efflux in a self-propagating fashion. So what we'll do is actually go through what that looks like. The American Society for Transplantation and Cellular Therapy generated a consensus system to help standardize assessment for clinical and research purposes. And this consensus grading has 4 levels across 3 domains, as stated previously: fever, hypotension, and hypoxia. So all of these will have fever as the basis. Grade 1 is fever only, greater than 38 degrees Celsius. Grade 2 will have fever and hypotension not requiring vasopressors and low flow nasal cannula. Grade 3 will be fever with vasopressor use and or high flow nasal cannula, which can be face mask, venti mask, or non-rebreather. Grade 4 is fever, multiple vasopressors, and mechanical ventilation, be it invasive or non-invasive. There's been some discussion surrounding whether or not higher grade of CRS confers an added benefit and is a signpost for potential success of the therapy in the future. A study in 2023 by Bhaskar showed that in patients receiving CAR T cell therapy, the development of CRS does not affect overall survival, does not affect progression-free survival or response rate. So, chimeric antigen receptor T cell therapy yields similar outcomes in patients with and without cytokine release therapy, yet this is still an area of investigation. Next, we will review ICANS, and this is a disorder characterized by a pathologic process involving the central nervous system following any immune therapy that results in activation or engagement of immune therapy that results in the activation or engagement of endogenous or infused T cells and or immune effector cells. Those signs or symptoms can be progressive, including aphasia, altered level of consciousness, impairment of cognitive skills, motor weakness, seizure, and cerebral edema. So this is a pretty busy slide, so we'll talk about this starting at the top left. There is a neurologic screen, the ICE assessment, that's usually done every 8 hours, and there are multiple domains. One of those domains is done daily, and we'll talk about that. There are issues explored concerning orientation, naming, following commands, and then typically once a day writing a standard sentence. So this is picked at the beginning of the process. They may say, my name is Gene DeCastro, or I am here for CAR T treatment. They'll have to write that sentence every day and it's evaluated. And then lastly, attention. So to the right, we have an example of someone who is undergoing CAR T therapy, and their sentence was, I love Shawnee, KS. And what's interesting is when you look at day 4, a mini mental was done, right, and their score. Day 5, the sentence is almost unintelligible, the reduction in the mini mental. And then on day 6, the penmanship is better, but the sentence is different, right? Not necessarily accurate. Now, this tool is used in concert with this consensus grading with alterations in mental status. And we have grade 1, 2, 3, and 4. And grade 1 would be an ICE score of 7 to 9. The person is awake spontaneously and no other domains of seizure, motor findings, or symptoms or signs consistent with elevated intracranial pressure or cerebral edema. A declination in the score is grade 2, and the person has some lethargy that can be inferred because they're awakening to voice. None of the other domains are present. And then when we look at grade 3 and 4, we see a significant reduction in the ICE evaluation, as well as depressed level of consciousness, potential for seizure, motor weakness, and cerebral edema on imaging. This is a great visualization that shows the timeline to CRS or ICANS. It's a nice overlap and diagram that highlights when the CAR T cells are expanded and what the cytokine profiles look like to get a good sense about when people should be surveilling for these symptoms so that they could understand from a mechanistic standpoint and clinical standpoint when one can expect these things. Now, interestingly, what's important to notice when we look at the toxicities, and to the left we have cytokine release syndrome and their associated grades and treatment, and ICANS associated on the right with its grades and treatments, is that there's an early involvement of ICU assessment or transfer as a means of providing support for these patients during these transient periods of decompensation. Now, what's critical here is that these individuals may have these therapies certainly just as a bridge. This may just be a bridge for a better outcome. Individuals with cytokine release syndrome may be getting tocilizumab, which is a well-practiced therapy and utilized therapy to manage cytokine release syndrome. And steroids are the cornerstone for CRS as well as ICANS. These supportive endeavors can be particularly helpful and an adequate bridge for successful outcomes. And there's an increasing body of literature analyzing the positive outcomes despite intensive care unit admission. This is the conclusion of our discussion on palliative care and hematologic malignancies, and we will finish by going over 2 board review style questions. 1, the patient is a 42-year-old woman with a past medical history of AML who is admitted for allogeneic bone marrow transplant. Initially, you saw her on day -3 as she received high-dose conditioning regimen and there were no symptoms. The bone marrow transplant team contacted you on day 6 to help manage the patient's mucositis. Upon examination, you see that she has grade 3 mucositis, and she reports that it feels like swallowing glass. Her white blood cell count is 0.2, hemoglobin is 10, and platelets are 42. She has normal kidney and liver function. What is the best option for treating her pain from mucositis? Is it A, IV ketorolac, 10 milligrams every 6 hours as needed? B, oral hydromorphone, 2 milligrams every 4 hours as needed? C, IV PCA hydromorphone, 0.3 milligrams every 15 minutes, demand dose only? D, mucositis is transient, so wait until it subsides? E, IV acetaminophen, 1,000 milligrams every 8 hours standing, and IV morphine, 4 milligrams every 6 hours as needed? I will give you a few moments to think about what you feel the best option may be. The answer is C, IV PCA hydromorphone. IV ketorolac would not be recommended because of the patient's thrombocytopenia. Option B would not be recommended because she has grade 3 mucositis and severe pain with swallowing. Grade D, mucositis is a severe symptom and she has grade 3 pathology and ought not to be ignored. And answer E should not be selected because individuals may be neutropenic and need a fever where IV Tylenol may blunt that response and mask neutropenic fever for these patients. Question 2, the patient is a 76-year-old man with a past medical history of multiple myeloma, chemo-induced peripheral neuropathy on duloxetine, CKD stage 2, and bilateral hearing loss, who arrived for autologous stem cell transplant yesterday. The hematology fellow consulted palliative care to follow the patient throughout his admission as part of the co-management model at your hospital. What symptom has been demonstrated to have sustained improvement up to 6 months after stem cell transplant with integrated palliative care? Is it A, pruritus? Is it B, depression? C, chemo-induced peripheral neuropathy? D, anxiety? E, constipation? I'll give you a moment to think about what you believe the answer is. The answer is B, depression. Pruritus was not studied and not an outcome measured in the studies that we've looked at. Chemo-induced peripheral neuropathy happens less frequently. Anxiety was not found to have sustained impact up to 6 months. Constipation is not the correct answer. I want to thank everyone for your time, and thank you for selecting this lecture today.